groups who were, and this actually AHIP as well, the health insurance industry group, to get them to support the general concept. But I think as a result, some of these organizations that did the 180 from 1993 to now have a lot of issues with their state-based associations. I think AMA, like half of them decided to split off. They decided we don't like what the national is saying.
I just found that mind-boggling when you talk about the price tag and the palatability of the price tag, and then you look at the bureaucracy of the process is going to be involved in managing the system, and at the end of the day, it's not going to address the overall issue of your universality. So I just can't even wrap my head around it, right? Because you're putting the money into the process of the bureaucracy rather than the service, and there's the diversion. If you talk about the price tag, I just don't get it.
Well, I'm wondering if the National Association, your hospital association, are you actively, most of the people in this room would probably support universal health care, but most of the people in this country would not. And that's kind of a reality that I think Washington understands. And so what I'm wondering is your association working to find ways to make our health care less expensive? I mean, the pay-for-procedure model we have costs so much money. And I think the doctors could have a role, but I think that the hospitals and health providers need to be playing a larger role in trying to help devise some sort of system of healthcare that is not so expensive and doesn't have projected healthcare cost increases that are going out the roof. And we can't afford the current system as a nation. So we have to come up with something different. Are you helping to find a new different or to?
Oh, definitely.
And what are some of the ways what would that look like? And what are some of the things that are driving this cost increase? And what are some of the things that you're proposing to avert that?
Sure. I had that right. Well, I'll tell you. So I mentioned earlier that health reform. I'm talking only about coverage expansion piece right now. There's the whole other what I like to call delivery system reform. Yeah. So the whole switch away from more of the fragmented care that's driven by some of the fee-for-service models to these seamless integrated care. Yeah. So medical homes, accountable care organizations, the bundle payment pilots and demonstrations, and global payment. All of these ideas with these different names, it's probably recycling of all old ideas. It's the concept of how do you actually manage the care of a population, and moving away from the fragmented system so that the theory is a patient coming in for emergency service and then discovers that they have something else, and there's follow-up that things don't get broken down, that they can't get that follow-up care, and if they need medication, they get the medication, and that somebody calls them at home to remind them to take the medication so that they're compliant, and that there's follow-up care so that when they do need something, they come back right away for it and not have to wait for a serious issue and come back. So there's a lot of that also in the health reform that I think it's at the very end of my presentation, and I wasn't planning on going into much detail about it, but it's all of these concepts of bringing different groups of providers together. So instead of a hospital sort of basically would make their money on the inpatient side, is instead of just encouraging more inpatient admissions so that you can just turn people out and do discharges and get payments for each person that you cycle through. It is putting the hospitals with the primary care physicians in the community together to make sure that the person's getting the necessary primary and preventive care, so that one, they're not going to the hospital for some of the preventable admissions, and two, that when they truly go, that there is access and you're seeing them at the appropriate stages. There's a lot of these, and in terms of NAPH as an association, part of health reform I will mention this a little bit later, but we got this provision in there called the community-based collaborative care networks, and the whole idea is for the safety net hospitals and the community health centers in a local community to partner and network, so that the patients going to the community health centers who need specialty referral, and we know from statistics that 25% of them will, that they have ready access to the specialists at the hospitals. And I think we talk about, I showed you the margin where public hospitals traditionally have less resources to kind of engage in a lot of these transformations. But what we do have, and where we're unlike a normal community hospital, is that we have a large ambulatory care network. So some of our hospitals own and operate federally qualified health centers or other community health centers. So they have this ready-made network already to be able to take care of the patient along the full continuum of care. With the investments in HIT, so that you go to one doctor's office, you go somewhere else, they have that information for you, and it's even easier when it's in the same system. So there are this whole other side of delivery system transformation of health reform that are, the concept has been around for a long time. The new ways of achieving that is what's being tested right now. So some of the accountable care organizations the regulation was just released about 2 weeks ago. This is on the Medicare accountable care organization. It says nothing about what may or may not happen in the Medicaid side, but at least we're starting to see what that looks like and how providers can take advantage. And that provision comes in, January 1 of 2012. So a lot of these testings are either currently underway or just about to start, so that they're set up to start in the pre-2014 period, so that you're testing the delivery system, figuring out how you can take care of more people for less money and produce higher quality, so that when the expansion really happens in 2014, you get that 10 million, in that 1 year, 10 million new Medicaid individuals in. But the delivery system is ready to take care of those populations. Yes?
I know that this session wasn't intended to turn into a debate on these things, and I don't intend to take it there. But with regard to the ACOs and the health homes and that sort of thing, and getting back to the question of complexity, before you even get out of this part of your presentation, and I'm sure you're headed there, there's this whole other set of things that the federal government is trying to figure out. The folks at CMS, senior people at CMS will tell you openly, they don't know what an ACO is quite yet. But nevertheless, this is a mandated model of change that somehow or another is going to have to be implemented as some of that division nationally. From the perspective of NAPH, between here and 2014, what is a practical matter? What opportunities are there to try to, for organizations, for anybody, to participate in defining what that looks like down the road?
Great question. NAPH actually, as a result of the health reform, it coincided with our strategic planning process for the next 3 years. We heard from our members, they very much would want our help in transforming into more integrated delivery systems. Now, we have members who are already there, but the majority of our membership would like to move in that direction. And so we're starting a transformation center where there's an action network, basically for the folks who are really ready to test some of the demos and the pilots to see how they can work. There's going to be a learning network and a knowledge portal to help both initially just within the membership of making sure everybody has the best practices, and then eventually it's going to be out to the public. So we are doing things as an association that's different than before to help our members produce higher quality care and transform their systems so that they can be ready for all of this. But to your point on ACO specifically, I don't know if any of you've heard, but as soon as the Affordable Care Act was passed, I heard so much about ACOs in the news, and you hear it being called medical homes on steroids or managed care 2.0. Also being referred to as any consultant's opinion. That's what ACO stand for.
What does ACO stand for?
It's accountable care organization.
Okay.
So that wasn't the rule, wasn't the law, but it is. There isn't one ACO model that exists out there. People have done different things to change the way they operate to deliver seamless coordinated care. And what CMS has a task of doing is, with the proposal they just released on the Medicare ACO, is trying to shape what the ACO looks like within the Medicare program. We know that through the new Innovation Center, they'll test other types of ACO. So we have a proposal in with them for a Medicaid ACO. It's really called the Safety Net ACO because we would like to focus on both Medicaid and uninsured patients. And then, there's a Medicaid pediatric ACO specifically authorized in the law. And the implementation for that one isn't, the details aren't out yet. But there's potentially all these other types of accountable care organizations that will be tested through the Innovation Center, and hopefully at the end of the day, people can desperately trying to get away from this slide. Should not have, in retrospect, I would not have put it in. But, yeah, so some of the questions to consider with these exchanges are, so we talked about with the Medicaid is the under 133. So this is the one above 133% of federal poverty level. Up to 400, they can get a subsidy. Above 400, they won't get a subsidy. But that's also where they'll get their insurance if they're not employed or on Medicare or Medicaid. And it really thinks about how this expansion of coverage through the exchanges will also impact your local community in terms of the mix of people who previously may not have had coverage who may get one now. And the one consideration with the exchange I think is that people don't normally think about because they always think about churning on Medicaid, but with these exchanges coming in, 133 is the cutoff. So if you're somebody with a job and you pick up another part-time job, you can be basically you can change so that you were under 133 before, and now you're above 133. And what happens? And so the whole ideally the thinking behind it is that because you'll be able to just go to this one portal to figure out your coverage, that when you do become ineligible for Medicaid because you make above 133 but you don't make so much and you can go off it and your employer doesn't offer health insurance, is that the transition from Medicaid coverage to a plan on the exchange will be seamless for you. That's certainly the goal. I mentioned implementation is, details aren't out yet, but those are the type of things that we're thinking about, that our members are thinking about, that when the regulation comes out, we'll certainly be commenting on how they can make that process more seamless. Because the last thing you want is to have all of these great coverage expansion options out there, and for a person who moves from 100% to 200% of income, and then all of a sudden they're uninsured for a period of time in the middle. With that, it's the same. It's enrollment and outreach and just education. In Washington, we hear a lot about the Affordable Care Act, but as I would suspect, and maybe you all will agree, that in the local communities,